Hey guys, it's Dr. BT, and I want to talk to you about fetal monitoring. There's going to be some information that you're going to have to know about fetal monitoring for my test and for the NCLEX. So we are going to review the essential information that you need to know about fetal monitoring. There's three different things that we look at. One is we look at the fetal heart tones, and of course that's the part on top when you're looking at a strip. The top is the fetal heart tones, and the bottom are the contractions. Okay. So the next thing we'll look at is the uterine contractions, which I showed you that at the bottom of the strip. And thirdly, we're going to look at, is there a relationship between the fetal heart tones or fetal heart tracing and the uterine contractions? So the first thing we're going to do is we're going to evaluate the fetal heart tones. Normal heart tones range from 110 to 160. Classically, they say 120 to 160, but 110 to 120 is a gray zone. And so if the baby has always been running 110, it's a normal finding. So things that can cause bradycardia, and bradycardia is less than 110 beats per minute, is anything that decreases the pressure to the placental site. So anytime there's not oxygen available for the fetus, the fetal heart rate will decline. Of course, we don't like it when the fetal heart rate declines because we know that that's hypoxia or a hypoxic situation. We know there's acidosis, and if this is not relieved rather quickly, it can result in brain damage. So anything that lowers the maternal heart rate can lower the baby's heart rate, such as maternal hypotension related to epidural. This is one of the most common causes in a dip in the baby's heart rate, is after the epidural and the maternal blood pressure goes down, and then there is decreased oxygen at the placental site. Beta blockers, of course, decrease maternal blood pressure. Congenital heart blocks, maternal hypothermia, and prolonged maternal hypoglycemia will cause decrease in maternal heart rate too, and blood pressure. So those are things that can cause bradycardia. Obviously, if the baby's bradycardic, we need to give the mom some oxygen so the oxygen can pass over to the baby via the placenta. So we give her 10 liters of oxygen on a non-rebreather mask. And then what we'll do to help it push over faster is to increase the blood pressures. We'll give her a bolus of fluid or a volume expander. So we'll give her like 500 cc's of lactated ringers or normal saline to help push that over. We'll also change her position. Sometimes the baby can be compressed on a cord and causing a vasospasm. So we turn the patient. If this happens as well, we turn the patient. Fetal tachycardia is greater than 160 beats per minute. The number one cause of fetal tachycardia is maternal fetal infection, specifically chorioamnionitis. And this is when there's an infection of the chorion and the amnion of the placenta, and the fetus is infected, and then mom is infected. And just like anyone who has a fever, your heart rate goes up. Another thing that can cause fetal tachycardia, and of course for that we would give antibiotics, and take temperatures. Once mom's water breaks, we take a temperature every hour to make sure infection doesn't set in, because we certainly worry after 18 hours. And at 24 hours, we're very concerned in interment. But early fetal hypoxia can cause tachycardia. Of course, street drugs, anything that causes the maternal heart rate to go up, that is ingested by the mother, that crosses the placenta, it will cause the baby's heart rate to go up too. Atropine hydralazine, Britadrin, maternal hyperthyroidism, fetal anemia, and fetal heart failure, fetal dysrhythmias, anything like that can cause tachycardia. But the problem is that you guys, if you have a normal heart rate, 110 to 160, and then during the labor, as it progresses, the fetal heart rate starts to rise, you really begin to suspect maternal infant infection. Okay, so now let's talk about what the actual fetal heart rate looks like on the paper. Okay, what the fetal heart rate looks like on the paper. This is called variability. And variability is controlled by the fetal brain through the sympathetic and parasympathetic nervous system. Long-term variability is the measure of the broad-based changes in the fetal heart rate or the waviness. So I kind of equate this to, the Glasgow Coma Scale. When someone's in a coma, they don't have this parasympathetic, or they have severe brain damage. They don't have the sympathetic and parasympathetic system intact. And so their heart just beats, but their brain is not influencing the heart rate. And so that would be this, undetected. And you can see on this tracing, it's 140, 140, 140, straight across, really no changes, undetected changes in the fetal heart rate. So it doesn't say 140, 148, 142, which is what we want. It's the consistent 140, and that tells us that we have some severe brain damage. So we don't want to see undetected. Minimal variability is when you're asleep. Many times when you're sleeping, you have decreased sympathetic and parasympathetic activity, but your brain is still working, but you're sleeping. So minimal variability is from undetected to 4 beats per minute. So you can see this is a little bit more wavy, and we know we have some brain to heart changes, but not very much. So it's okay only for 20 minutes out of every hour, because babies sleep 20 minutes out of every hour. So if we have minimal variability, a lot of times the intervention will be to get some caffeine, get something sweet, give it to the mother so it passes over the placenta, and the baby gets it and wakes up. Then we want to be able to see moderate variability. Moderate variability tells us that we have a good sympathetic and parasympathetic nervous system. The heart and the brain are reacting together, and we want to see this nice squiggly line. So it's like 6 to 25 beats. So not like when you're sleeping, but this is like when you see someone, say for instance you're single and you see someone attractive and you're like, wow, and you get these little flutters. That would be that. Or you see your favorite, or how about your sports team scores a goal or hits a home run, and so your brain and your heart react. So this is really what we want to see. We want to see moderate variability. And then marked variability is ominous. We do not like marked variability. It can mean early hypoxia. You can see down here. Significance is unknown. This is it right here. But it can be marked. It can be early hypoxia, and it can even be fetal seizures. So that is when this line is so thick and it changes so dramatically, it's greater than 25 beats. So what you would like to see here is moderate variability, 6 to 25 beats. Again, undetected can mean brain damage. Minimal variability could mean the baby is sleeping 20 minutes out of every hour. We would not want this to continue after 20 minutes. Moderate variability is our goal, and marked variability has us very concerned. Fetal seizures or hypoxia. So the next thing I want to talk to you about is an acceleration. An acceleration is a form of long-term variability of particular significance in the fetal heart tracing. And this is what it looks like. So remember, long-term variability is 6 to 25 beats above the baseline. So we can see on this particular tracing that 150 is the baseline, and we can see the heart rate go up 20 beats on this one, and we can see the heartbeat on this one go up about 15 to 20 beats. And these are called accelerations. Accelerations are always a good thing. What they mean is that, I'm sorry, my dog is barking. I think he's stopped now. Okay, so accelerations are always a good thing. It means that when the baby moves, he or she can get enough oxygen through the placenta to supply his or her muscles and heart with oxygen. So when the baby moves, there will be these accelerations. Babies who cannot ascertain oxygen through the placenta will not move. So one of the biggest questions, or one of the most serious questions that we ask women when they come in for fetal monitoring is, have you felt the baby move? When they say yes they have, that's very reassuring. When they say no they haven't, that concerns us that there could be damage to the placenta or the cord and the baby is not getting enough oxygen. So you guys, whenever we bring people in, or people are at high risk, people such as diabetics, hypertensives, people with thyroid disease, people who smoke, people who do drugs, any of those things, we do this test on them called a non-stress test. Non-stress meaning no contractions, because obviously when you have a contraction, I'm going to scoot down here, I'm going to show you the anatomy of a contraction. When you have a contraction, there is obviously the uterus contracts, or it squeezes down and manually compresses the arterioles and veins. So you can see here at the beginning of a contraction, there's normal flow through the uterus. Okay, there's oxygen being placed to the gap. There's reduced flow or reduced oxygen going to the gap during the start of the contraction, where it increases, and then at the peak of the contraction, the arterioles and veins are completely shut. There is no flow coming through into the uterus. There is no oxygen going through the gap. And you can see, and where it declines, there is reduced flow, or there's some oxygen coming. And then after the contraction is over, there's normal flow coming in and out, or normal oxygen being pushed over to the gap. So you can see normal oxygen being transmitted to the gap, and normal CO2 being picked up from the gap. And you can see at the onset of the contraction, there is decreased oxygen going to the gap and decreased CO2 being picked up. At the peak of the contraction, there is no oxygen going over to the gap, and there is no CO2 being picked up from the gap. So you can see, if we had a contraction that lasted 5 minutes, how a baby would be completely hypoxic, no oxygen, and be acidotic because no CO2 was picked up. Then you can see where it comes down. There's some oxygen exchange and CO2 exchange, and then there's normal flow. So I just want to show you the anatomy of a contraction. So when we say you have a contraction, we say you have stress, or the baby has stress. So we call the contractions stress. So we have a non-stress test. And again, we do these non-stress tests on people who are high risk, or who have a risk of the placenta not supplying the baby with enough oxygen. I mentioned all of the other diseases, but I negated to tell you that an old a placenta after 42 weeks, remember the placenta grows, it supplies the baby with enough oxygen, and then it will start to age, and it will weather, and it will not supply the baby with oxygen. The arterioles and veins will start to calcify. So anybody with a high-risk condition, we're going to do a non-stress test on them. We're going to bring them in. Now, of course, on this particular tracing, you do see some stress, but we're going to pretend like these contractions are not there, because all we do is we put the mom on the monitor and we look at the fetal heart tones. And so we want to make sure that there's 2 accelerations in a 10 to 20 minute time frame. And that tells us that we have it tells us that that the baby's being supplied by enough oxygen, enough CO2 is being removed. So these accelerations say there's enough oxygen going to our baby. Again, to classify them, it has to go up for 15 beats, and you can see this one goes about 20, and it has to last for 15 seconds in a term baby. So you can see this one meets criteria. It goes up for 15 beats and it lasts for 15 seconds. This one too, it goes up for 15 beats and it lasts for 15 seconds, because you can see these little boxes are 10 seconds. So if you have 2 in a 10 to 20 minute time frame, that's deemed a reactive non-stress test. So that means the baby's heart rate reacted and had accelerations. A non-reactive non-stress test is where the fetus did not meet the acceleration requirements. Of course, the potential causes could be fetal sleep, and we know they sleep 20 minutes out of every hour. So we'll continue to monitor them. We'll give them glucose and give maybe some caffeine. Or it could be fetal hypoxia due to the placenta not functioning well, and they would need further testing with a contraction stress test and or a biophysical profile. And we'll talk about a biophysical profile when we talk about high-risk obstetrics. Okay, next is evaluation of uterine contractions. So now you guys, these uterine contractions, these little blocks are 10 seconds. So we can see from this contraction how long it lasted. It lasted 10, 20, 30, 40, 50, 60, 70, 80 seconds. So that would be the duration of the contraction, 80 seconds. This is the increment, here's the acme, and here's the decrement. And then this relaxation period, you know, we need this relaxation period because we need normal arterial transfusion to the gap. We need oxygen to be pushed over to the gap and CO2 to be picked up. So the resting phase is just as important as the contracting phase. The contracting phase pushes the baby out and dilates our cervix, but the resting phase gives our baby some more oxygen. The last thing we need to talk about is the frequency of contraction, and the frequency is from the beginning of one contraction to the beginning of the next contraction. So we can say that roughly it started right here on this red line. So we can say these are 1, 2.5 minutes apart. From this contraction to this contraction, you measure from the beginning of one to the beginning of the next. Let's check from this one to this one. This one is, and then we started on the 1, 2 on the third line. So we would say this is 1, 2 minutes apart again. And in my opinion, and in all the monitoring opinions, this is a little too much. They need to be every 3 to 5 minutes, lasting 45 to 90 seconds. And we've already talked about the anatomy and the physiology of the placenta and the contraction. You guys, if someone, we were trying to get them to go into labor and we did an induction of labor, we used the drug called Pitocin. We can give it IV. The nurse can titrate this, and what's funny is these have changed. These are every 3 to 5 minutes. So you would never want the contractions to be greater than every 3 minutes if you were giving someone Pitocin, lasting, so we only want them 45 to 90 seconds. So if it was greater than every 3 minutes, like we have in this strip here, these are every 2 minutes, that would be hyperstimulation, and it didn't give the baby enough resting time. So we would want the contractions, we would not give the mother more Pitocin, or which is a form of oxytocin, because we know that it could cause hypoxia for the baby. Now, the last part of fetal monitoring is evaluation of the fetal heart tones in relationship to the uterine contractions. So you guys, when you're looking at the fetal heart tones and we're looking for decreases in fetal heart rates related to the contractions, when you see decreases on the fetal heart tracing such as these variable decelerations are U, V, and W shaped. They're abrupt. You see how they go down? This one's U, this one's W, this one's a U shaped. You can see down here, here's a severe one that's a big U shape. And they're just very abrupt. You can see they're not smooth. They're just changes. What this is, and they don't make sense compared to the contraction. So you see a contraction and you see a variable, but really the variable has nothing to do in timing with when the contraction came. There's no pattern. And so you guys, if it goes down 15 seconds and it goes down, it looks like an acceleration, like kind of upside down. When we have these variable decelerations, we know that these are cord compression. We know the water comes out when the water breaks. The baby can roll over on the cord, and when the pressure is put on the cord, we see these very dramatic, abrupt dips. And when we talk about NCLEX testing and we talk about my testing, these abrupt dips are U, V, and W shaped, and they have no bearing or relationship to the contraction. So you guys, if it's cord compression, obviously The nursing interventions would be change position to remove the force. It's usually the baby laying on it, which is compressing the cord. If they're really deep like this, you guys, and we think that our baby might be a little hypoxic or acidotic, of course we're going to give 10 liters per non-rebreather. If they're really severe and mom is dilating adequately and the provider feels like that her contractions will continue and that potentially we can instill some fluid into the uterus, this is called an amnio infusion. This is where a pressure catheter is put into the uterus and fluid is delivered into the pressure catheter. And actually, I'll have your book right here. I'll tell you what page it's on so that you can read further about an amnio infusion. Let's see. Well, they don't have it per se. Let me see. 444 and 445 they say is assistant. So let's see if that's correct. So, no, this just really talks about membrane ruptures. And of course, you guys, all of this information that I've been going over with you is in your book. I will point you to that at the end of this lecture. But these variable decelerations, again, you guys, we can float fluid in and hopefully free the cord from the mechanical force. If there is Pitocin running or oxytocin running and there are contractions, and remember, with variable deceleration, there is no relationship between what the decelerations look like and the contraction pattern. But if there are contractions and there is a severe decrease in heart rate, we know our baby may be becoming acidotic, so we may want to consider turning off the Pitocin. Okay, now there are two more forms of decelerations that you need to know about. Okay, two more forms of decelerations, and these have a direct relationship to the contraction pattern. So whenever you're looking at your contractions and you're looking at decelerations, you're going to draw a line in the middle of the contraction straight up. And you can see that this is a contraction and there's a line going straight up. And you can see this very smooth deceleration, very, very smooth. It's not UV or W shaped. It's just a very smooth deceleration that is at the same timing as the contraction. You can see that it started when the contraction started. This is why we deem these decelerations early deceleration, because the deceleration started prior to the peak of the contraction. You can see this one started prior to the peak of the contraction. All this is head compression. When the baby's head goes and is pushed down into the pelvis and gets the vaginal squeeze, the head does, it creates a vagal response and the heart rate goes down. After the contraction and the baby, has not been pushed down further again, it will let up, and that's how we know that it's simply merely straightforward head compression. So when we see the deceleration start prior to the peak of the contraction, we're happy. These are a good thing. These are called early decelerations, and this only means head compression. Head compression is great because we need head compression for a vaginal delivery. There are no interventions for early decelerations. Late decelerations, however, are again very smooth, and they don't look like a UV or W shape. But they occur after the peak of the contraction. So you can see here's the onset of the contraction, and then here's the peak. So these are deemed late decelerations because they start after the peak of the contraction. So you can see here the baby is getting less oxygen, less oxygen. Now there is no exchange at the peak of the contraction. The baby has no reserve left, so the baby's heart rate will start to go down. These are very, very ominous. They mean fetal hypoxia for the baby being, it does not have any reserves. Just the simple insult of one contraction or being without oxygen for this short period of time, in this instance it would be 30 seconds, cause the baby's heart rate to go down and become hypoxic. So we do not ever want late decelerations, and again they occur after the peak of the contraction. Most common causes vascular problems with the placenta. The placenta is calcified. It's from smoking, the old placenta, post-age drugs, gestational diabetes, hypertension, and could be hypotension secondary to the epidural. If the placenta is not in good shape. So what would be the interventions you would do here? Well, the number one thing is you always change maternal positions first, because the baby could be laying on the placenta, laying on the cord. So let's go ahead and roll the patient. We can put them on their side or on all fours. If there is Pitocin infusing, we know that's causing contractions, and contractions are causing the hypoxia. So of course we would turn it off. This will stop the endometrial arteries from closing, which will allow more O2 to the fetus. We will give oxygen per 10 liters non-rebreather, a fluid bolus to increase the pressure at the placental site to push over the oxygen, and we would notify the provider. If unable to correct, they're going to do a C-section, because we do not want a hypoxic, acidotic, brain damaged baby. So you guys, very important that you understand these strips. There is a little mnemonic that I'm going to type on you here for you, and it is called veal chop. Okay, so variables mean cord compression. And of course with this one, we're just going to change positions and hope that this fixes it. Early decelerations are what? That's right. That is head compression. And this is a good thing. This means that we have a baby coming and there are no interventions. A are accelerations. So here's your chop. So we got veal, V-E-A-L on that side, and on this other side we have C-H-O. So accelerations are okay, meaning the placenta is in good shape. And able to give oxygen to the baby and take CO2 from the gap. And then late decelerations. And what late decelerations are considered are utero, placental, and this is the P, insufficiency. So utero-placental insufficiency, and that P is from placental insufficiency, and that's the actual technical name of the condition when the baby becomes hypoxic due to the contractions and the aging placenta. So utero-placental insufficiency means late decels. This is always bad and always ominous. So remember, our interventions again are changing positions, turn off Pitocin, give O2 at 10 liters in a non-rebreather, fluid bolus to increase the pressure, and call provider. And you're going to call the provider if you repair this or if you don't. Obviously, if you don't repair this, then we're super concerned that we may have to have a C-section. So we're super concerned about that. So this VE, this is a way for you to remember it. A L, veal. These are the type of changes that you'll see in the fetal heart rate. And these are the meanings of those, so VL CHOP. So remember that UV and W shaped heart rate changes are core compression. And early and lates are really smooth. They don't look like the UV or W shape. And then here are the things that you can do for your condition. If you have any questions, please post it on the discussion board. Thank you.